Yes.
our experience with you about bladder-preserving surgery and brachytherapy as management in urogenital rhabdomyosarcoma. We heard a little bit about brachytherapy, and I'm going to give you our view from the surgical standpoint. So, rhabdomyosarcoma is the most common soft tissue sarcoma in children, as you well know. 15 to 20% are located in the genitourinary region. Most often, these are bladder prostate rhabdomyosarcoma. The classical treatment concept that was focusing on survival included aggressive surgery and local irradiation. However, in recent studies, other characters have also become into the focus, such as bladder preservation and bladder function. These are now included as outcome parameters in most studies. So aim of treatment in bladder and prostate rhabdomyosarcoma these days is, of course, to improve survival and to reduce treatment intensity, but also to minimize side effects and to achieve high bladder preservation rates and good bladder function. So for local control, we have two possibilities: radiotherapy, surgery, or the combination of both. And you see listed the factors that influence the decision-making process towards one or the other, or the combination of both. Challenges of local therapy, as well as surgery, include the factors that are listed here. And for every child, we need to achieve an individual risk assessment. So you see that radiotherapy and surgery do have challenging aspects, and it is part of the decision-making process of the interdisciplinary team to go ahead and find this individual risk assessment. And from the surgical point of view, the bladder prostate region, or the region of the bladder neck, and the proximal urethra are a very, very challenging region. So if you look at the different types of therapy and possibilities where surgery is placed, you see on the left that surgery can either take place after biopsy and chemotherapy, or in the middle after an additional application of irradiation, or on the right, if an incomplete surgery has been performed initially, then after irradiation, surgery can again take place to achieve complete resection. So this also adds to the individualized treatment concepts for every child. Urological challenges in surgery of bladder prostate rhabdomyosarcoma are the ureter reimplantation. We have to consider whether we have to reimplant into the bowel or the bladder remnant. Protection of the bladder remnant with knowledge of the blood supply is crucial. Then the management of the ureters is very, very challenging. Bladder growth and bladder capacity in the growing child is something that we need to consider before making our decision. And then complications with urinary diversion, such as, for example, the trophonous channels, urinary continence, and also long-term side effects are important measures. So the protection of the bladder remnant has a high priority for the urological outcome. So we have concepts for partial and for total bladder preservation. On the left, we have the possibility for bladder reconstruction with augmentation. However, during recent years, on the right, bladder reconstruction without augmentation has become more and more focus of surgical research. Predictors for the surgical outcome are tumor extension, response to chemotherapy, and tumor histology. And of course, we need a good preoperative diagnostic workup. So assessment of the trigone and the detrusor muscle is crucial. And this is especially true if we are thinking about bladder preserving surgery as opposed to bladder reconstruction without bladder preservation. In our concept, we have the anterior approach for bladder prostate rhabdomyosarcoma, and we always go with transection of the symphysis. You can see on the left lower picture, the patient is positioned with the head on the left, the legs on the right, and you look through the open symphysis on the bladder region before dissection. And on the upper right, this is after completion of bladder dissection, and we see here the bladder neck and the proximal urethra together with the extension of the bladder trigone. So this transection of the symphysis gives an excellent view And this is something that is crucial for bladder preservation. On the bottom right, you see the open bladder with tumor in the region of the trigone and the implanted catheters in the ureter and the proximal urethra. This is where the tumor is. As I mentioned already, blood supply of the bladder is crucial, and we need to know the anatomy, and we need to know how to go ahead in this very, very confined anatomical region. So this is the same view of the patient, a little bit enlarged, and you can see here the open symphysis and the proximal urethra and the bladder. And here you see the secured bladder vessels, and knowledge of this and securing of this is something that is inevitable if we want to secure and preserve the bladder. Without augmentation, we have to consider several technical aspects. So, as I mentioned, the transposition of the ureters is something that needs to be addressed. The ureteral reconstruction of the trigone is essential. Together with preservation of the detrusor muscle, we perform a marginal R0 resection of the tumor, at least. In some cases, marginal R1 resection is mandatory. If that's not possible, then bladder preservation has to be reconsidered. Protection of the sphincter muscle is also something that is crucial, because if we want to achieve a continence with good urological and oncological outcome, this is something that has to be addressed. The history of brachytherapy in genitourinary rhabdomyosarcoma started in the late 90s with the Paris group around Helen Martelli reporting on 18 bladder prostate rhabdomyosarcoma patients undergoing bladder resection with a low-dose rate brachytherapy. This group later shifted to a pulsed dose rate brachytherapy, and they reported over 30 patients undergoing this concept. In Tübingen, we perform a little bit different approach with high-dose rate brachytherapy. So this might be a little bit misleading, but high-dose rate means the single applied dose. So this is something that I'm going to show you in a moment. And another difference to the Paris group is that the Paris group accepts macroscopic tumor rest, which we don't. The principle of brachytherapy have been shown in one of the previous presentations. So in genitourinary rhabdomyosarcoma, we are putting the tubes inside the tumor, inside the body after tumor resection, and we apply this internal irradiation postoperatively. Brachytherapy enables and supports less mutilating surgical procedures and is one of the preconditions for bladder-preserving surgery in some cases. It is highly active on the clinical target volume, and it spares organs at risk, especially growth plates and the rectum. And we have achieved comparable favorable data compared with conformal radiotherapy, intensity modulated radiotherapy, or proton beam therapy. So these are our selection criteria in Tübingen. Which patients are amenable for bladder preserving surgery plus brachytherapy? We do it in cases in which the tumors do not reach above the level of the bladder trigone, in which the tumors do not infiltrate blood vessels of the bladder, in which R0 or R1 resection status is achievable, and sphincter resection can be avoided. Another precondition is that preservation of at least half of the trigone is possible, and half of the bladder wall remains for reconstructive procedures. For planning of the brachytherapy, we use a three-dimensional image-based planning with linear quadratic model. This is based on the preoperative or pre-therapeutic MRI, as well as on intraoperative findings and the planning CT and MRI scan. As software, the colleagues from irradiation therapy use the Brachytherapy. This is just an image to show you how the strategy is applied. So the total planned dose is 36 gray with clinical target volume coverage aimed for over 90% of the prescribed dose. And doses for the organs at risk, as are mentioned here, are very, very low. And this is something which would never be achievable with other modalities of irradiation, provided that we have this target volume as I've shown you. Positioning of the tubes, as I mentioned, is done intraoperatively. So we put in the tubes through the perineal region, as you can see on the bottom right, and into the cetus around the former tumor bed. In selected cases, an additional transurethral tube is placed. The distance between the tubes at the target place is below 8 to 10 millimeters. This is our protocol. We have a protocol which starts on day 1 with surgery and tube placement, and on day 2 with brachytherapy planning using CT or MRI scan. In some cases, very recently, we did this already now also on day 1. As you can see on the arrows, 3 gray brachytherapy is applied twice daily for 6 and another 3 days. So this is for 12 days altogether, and it sums up to 36 gray altogether. The fluoroscopic and external length probe of the tubes is done, as you can see here from the protocol. During the complete time, patients are in general anesthesia on the intensive care unit, and they are transferred to the irradiation unit twice daily. So until now, we had this performed in 39 patients, 31 of which had bladder prostate rhabdomyosarcoma. Median age at surgery was 26 months, and tumor histology was embryonal in all cases. Tumor origin was bladder and prostate in most of the cases, with bladder or prostate in some of them. We put in a mean of 6 tubes with transurethral tubes in 14 patients. In 6 of them, we had to revise the tubes after the first control because of displacement. Mean CTV was 7.3 milliliters, and the fractional dose, as you can see here on the organs at risk, are in the area where we wanted to be. For surgical standpoint, we had urinary leakages as only complication in 9 patients, and this is seen on contrast-enhanced fluoroscopy on day 10, as you can see here. In all the 9 patients, the treatment was conservative, and none of them required redo surgery. So we just left the transurethral catheter in place and waited for a time up to 3 months, and then the leakages had disappeared. From the oncological standpoint, follow-up is 16 months. Overall survival was 100%. All the children survived with 5 tumor relapses. You can see here we had 2 local relapses and 3 lymph node relapses, and you can see the management of the relapses. 1 of the local relapses underwent reoperation, and 2 of the lymph node relapses underwent reoperation. Concerning urological outcome, bladder function is normal in 21 of 29 patients where we have the data from. 7 of them had urodynamic tests. The others were on history taking and on clinical and voiding urography. Bladder dysfunction was observed in 8 patients, with all of them being urinary continent, but having pathological intravesicular pressures. So 6 of them are on anticholinergic therapy, and 2 had urinary diversion using Mitrofanov stoma, 1 primary, 1 secondary. So in conclusion, the bladder-preserving surgery and brachytherapy represents a multimodal, individualized treatment approach for a selected group of children with urogenital rhabdomyosarcoma. Brachytherapy is a fundamental factor for bladder-preserving surgery. We have a high coverage of CTV and sparing of organs at risk with an excellent oncological outcome. However, the assessment of functional outcome has to be done through international cooperations to the relatively selection of the group. Thank you for your attention.